Today I'm going to be talking about a relatively new technology to our hospital, but not necessarily one in the medical world, in hopes of changing some ideas about the future use of End-tidal CO2 monitoring in the emergency department. Our objectives today are to gain a clear understanding of what capnography or End-tidal CO2 monitoring is and its clinical uses in the ED setting. We'd like to learn what capabilities LHSC has for End-tidal CO2 monitoring. We'll have a little bit of a demonstration for that. And hopefully familiarize ourselves with the local equipment setup and use. So for those of us who don't spend a lot of time in the ICU and haven't done an anesthesia rotation in quite some time, I'm just going to do a brief reminder of what capnography is and the physiology behind it. So it's the non-invasive measurement of the partial pressure of carbon dioxide in exhaled breath. So it's also referred to as entitled CO2, partial pressure of entitled CO2 or PET CO2, or capnography. It's expressed as a concentration of carbon dioxide over time and graphically expressed as a waveform, or the capnogram, which should be identical in shape in all humans. On the monitor, you should have both a number and the waveform. So why should we be using it? Well, as we all know, in the B of our ABCs, there are two processes, oxygenation and ventilation. And pulse oximetry gives us pretty decent real-time feedback on the adequacy of oxygenation, but not on ventilation. Capnography will allow ED physicians to not only assess the adequacy of ventilation, but assess perfusion and cellular metabolism. I'll go on to try to teach that it can be used to assess disease severity, response to treatment, and is the most reliable indicator of successful ET tube placement. So about using the SAT monitor versus capnography. As we know, hypoxia follows hypoventilation or apnea. So capnography can recognize hypoventilation, airway obstruction, or apnea earlier. This will facilitate the corrective measures that need to be undertaken before the onset of the hypoxia. Administration of oxygen when a patient is sedated maintains oxygenation of the tissues for longer intervals after apnea, and therefore might delay the detection of the apnea or hypoventilation. So relying on pulse oximetry alone can decrease our margin of safety, as corrective actions are taken only when the pulse oximeter starts to beep because the SATs are dropping. So bear with me as we do a brief review of respiratory physiology. We're going to be referring to the tidal volumes, which is made up of your alveolar volumes and your dead space volume. At the end of an inspiration, assuming that there's no rebreathing in your tidal volume, the tidal volume and lungs are filled with essentially CO2-free gas. So because the concentration of carbon dioxide in air is low enough that it's considered a trace gas. Carbon dioxide diffuses into the alveoli and equilibrates with end alveolar capillary blood. So the partial pressure of carbon dioxide in the alveolus is about 40 millimeters of mercury, and your normal AA gradient is less than 5. The actual concentration of carbon dioxide in the alveoli is determined by the extent of ventilation and perfusion, or your VQ ratio. And as you move more proximally in the respiratory tract, the concentration of CO2 falls gradually to essentially zero. And this volume of gas is the respiratory dead space, the physiologic dead space being the anatomical dead space plus any caused by VQ mismatch. During steady state gas exchange equilibrium, the partial pressure of carbon dioxide in the alveoli, the tissue production of carbon dioxide, or VCO2, and alveolar ventilation, VA, are related by the following equation. So using this equation, we can see that the partial pressure of carbon dioxide is directly proportional to carbon dioxide production in the tissues and delivered to the lungs based on our cardiac output and shunting. And it's inversely proportional to alveolar ventilation based on our tidal volumes and our respiratory rates. Just a final word on VQ mismatch, essentially three types. We have physiological shunting, where the blood passes the alveoli, causing severe hypoxia when there's over 20% bypass of the blood. This is in states like pneumonia, atelectasis, tumors, mucus plugging. You can have alveolar dead space, where there's inadequate perfusion, like pulmonary embolus, cardiogenic shock, or mechanical ventilation with increased tidal volumes. And you can have silent units where both V and Q are decreased, like in a pneumothorax or ARDS. So now in using this knowledge, let's apply it to capnography. This is an example of a standard capnographic waveform. It can be broken down into 4 phases. Phase 1 in red from A to B is dead space ventilation. So this represents the beginning of an exhalation where the anatomic dead space is cleared from the upper airway. Phase 2, in blue, from B to C, is the ascending expiratory phase, representing the rapid rise in carbon dioxide in the breath stream as the carbon dioxide from the alveoli reaches the upper airway. C to D, in green, is the alveolar plateau. So this represents the carbon dioxide concentration reaching a uniform level in the entire breath stream from the alveolus to the nose, with point D occurring at the end of the alveolar plateau, representing the maximum carbon dioxide concentration at the end of a tidal breath, and is appropriately named the End-tidal CO2, and the number you see on your monitor is measured from this point. This number in a normal person should be anywhere between 35 and 45 millimeters of mercury. In phase 4, D to E in yellow is your descending inspiratory phase, the rapid decline in carbon dioxide to zero as the patient inspires CO2-free gas. So imagine you have a 22-year-old male, head injury at work, comes in GCS of 5. He has no past medical history, he's on no medications. You intubate the patient, you hook him up, and this is the capnogram that you get. You've got uniform waveforms with a slow alveolar plateau, an end-tidal CO2 in the high 30s, under 40. Can anyone tell me what this would represent? Don't shout it all out at once. I knew you were thinking it. This is normal. This is what a normal capnogram looks like. The end-tidal CO2 of 35 to 40, a flat alveolar plateau, and a gradual upslope. So what about this patient? You're the staff on. If a patient come into resus, your medical student says, I'm going to take the airway, and you reluctantly agree. Patient is intubated successfully, and the excited medical student is bagging away. Anyone tell me what this might represent? As you can see, the height of the capnogram is decreasing over time, frequency is increasing. Hyperventilation, thank you. So hyperventilation from overzealous bagging can occur in a non-intubated patient with acidosis or PE. And just the opposite, as you can see, the end-tidal CO2 is slowly and gradually increasing over time, continuing to have a return to baseline, which represents hypoventilation. Again, in a non-intubated patient, opioid overdose, CNS dysfunction, or in an intubated patient, an insufficient rate of bagging. So what about this one? So rapid decline in the end-tidal CO2. I can ask for 2 different reasons why this might occur. First one to answer is probably going to be the obvious one and the easiest. Anybody?
Cardiac arrest.
So true in prolonged cardiac arrest, and I'll be talking about that later. So if cardiac arrest has been occurred long enough that all of the cellular metabolism essentially is turning to zero, or if you're getting an adequate CPR. Anything else? Could be apnea in a non-intubated patient. Absolutely. Could be dislodgement of the ET tube, total obstruction of the tube. As I said, apnea, respiratory arrest in a non-intubated patient could be due to equipment malfunction or prolonged cardiac arrest. Now this one's slightly different. This will represent some disease processes, but may also occur potentially in healthy lungs depending on the equipment. As you see here, we have an end-tidal CO2 that is higher than normal, up to 50, but we also have a much sharper slope in the alveolar plateau. So this occurs in incomplete airway obstruction, whether it be from asthma or COPD, or potentially incomplete obstruction in the tube itself, whether it be a kinked tube or a tube obstructed by a mucus plug, but not complete obstruction. This is a little more difficult one. As you can see here, the baseline of the capnogram is not returning all the way to zero. And each time, the baseline is a little bit higher. This elevated baseline represents air trapping, which can occur in asthma or COPD, or if you have a circuit issue in the ventilator, so you're getting CO2 rebreathing. So what are we currently using and what are we comfortable with? I hope we all recognize this, the colorimetric End-tidal CO2 detector, looks for a color change. You attach it to the ET tube after intubation, turns yellow, great, or through the cords. As you can see here, this depends on the amount of carbon dioxide coming out in the tube. If it's less than 3 milliliters of mercury, it'll stay purple. If it's 3 to 15, it'll turn a little bit tan. And you only get a true full yellow coloration if you get more than 15 millimeters of mercury or carbon dioxide. What we'll be talking about today is quantitative measurement of the End-tidal CO2. And there are essentially two different technologies. There's mainstream and side stream. We have capabilities for both here. The capnography uses infrared radiation, which is absorbed by carbon dioxide at a very specific wavelength to measure the CO2 concentrations. Mainstream devices measure CO2 directly from the airway and are in general attached as an adapter right onto the ET tube. It's really only configured for intubated patients. Side stream systems are configured for both intubated and non-intubated patients. These devices measure respiratory gas by aspirating small samples from the exhaled breath through either a cannula or tubing to a sensor located inside the monitor. These systems can be configured to both low and high flow rates. So low rates around 50 cc's per minute, high anywhere between 100 and 150. The flow rates are according to the amount of CO2 needed in the breath sample to obtain an accurate reading. And low flow systems have lower occlusion rates from moisture or patient secretions. They're more accurate in patients with low tidal volumes, like neonates, infants, adults with hypoventilation or low tidal volumes. And they also are resistant to aspirating supplemental oxygen and getting dilution. So do we have it here and where can we find it? You may recognize this as the back of the UH resus bay. These storage units are found in each of the bays, 1, 2, and 3. Each of these boxes contains a CO2 module for the monitor, a water trap, T-connector, and gas sampling line. And these are pre-configured and essentially plug and play. Now, Myron's going to come up and talk about the equipment we have here and how to troubleshoot and set it up. But just know that these are available inside each of these boxes. You've got the module with the water trap there, T-connector, your gas line. And it's very easily put together, although that we should all know how to do it. It'll likely be done by RT and hopefully nursing if they're not available. We have a slightly different system currently in the resus room at Vic, but I believe that those are going to be updated. They're also available at the back, and there you go, can't miss it. So I'd now like to invite Mr. Myron Steinman up just to go through some of the equipment we have here at LHSC, how to set it up.
There's not a whole lot to add to this talk, to be honest. The pictures are going to do probably a better job than what we're going to be able to show here. We really have a couple of units. We have both side stream and mainstream in this organization. The portable units that we have at UH and in the recess rooms at Vic, I believe, are the mainstream model. Really, we can only do those with intubated patients. And if I have my preference for the UH setting in the recess room or in conscious sedation, I would go with side stream models, I think, all the time. Rationale, we can use it for non-intubated patients. So just far more versatile, and it's less technically problematic. For this one, if you'll notice, I plug the cable in. Now it has to warm up. Then we have to calibrate it, do a 2 to 3 point calibration. So we're looking at a 2-minute warm up, plus another reference cell to reference it to 0 and then to the normal CO2 range. So if we're in a merge and somebody's tanking in the recess table, or we're trying to do whatever procedure we want to do, you're going to have a probably 3 to 4 minute wait to get those numbers. So it can be very frustrating for the clinician at the bedside to try to go through those steps. Where the side stream technology, which you've shown the other picture here, which essentially is this technology here, a little click in the monitor, it snaps in, there's a little water trap that snaps into that module. The water trap's important, as Brendan mentioned, because it will suck up secretions and some bit of moisture with it. Mostly for your patient population, We're not going to get lots and lots of goop put in there. But occasionally people in the ICU, we don't like this in the ICU because there's lots and lots of secretions and pneumonia in the ICU, and you get lots of crap building up in that circuit, and it occludes us off all the time. So this isn't a great one for the ICU, but a great one for emerge. Mainstream is probably a little bit better for our ICU. Does that make sense to people? Okay. So then it's very simple. This goes onto the monitor. We collect a little tubing connection from there to however we want to connect it to. We can connect it to a special set of nasal prongs, and the patient just exhales with the nasal prongs, and we get a waveform up. It is fabulous. As discussed, excuse me, puberty. As discussed, it one of these days I'm going to have to shave in the morning, get hair on my chest a little bit. As discussed, there's two variables with Untitled CO2. One is cardiac output, one is alveolar minute volume, right? So if all things are the same and the changing waveforms that Brendan had actually shown, so if we have an unstable cardiac patient and we're watching post-arrest and their waveforms are decent and then they start to drop, if they're on a ventilator and we're controlling the ventilation, if the waveforms are dropping, that means their cardiac output is dropping. Does that make sense? So there is a decent correlation with Untitled CO2 and alveolar minute volume, but we can't always be guaranteed that because there's two variables. So if we can control one, which is ventilation on some of these people, it can tip us off whether this person's heart or cardiac output may be actually turning on us. If we want to connect this to somebody who is breathing on a mask, this is a trick that anesthesia uses quite frequently, I'm told. They take a 14 gauge catheter, simple oxygen mask if they're giving oxygen in that manner. I'm not sure if I can pinch this off or not. We cut off the entitle or the catheter, wedge it into the mask, and now you can actually measure from somebody who's taking oxygen on a mask this way. Take this number with a little bit of a grain of salt, simply because there's oxygen that's flushing through it. It's pressure fed. So if I could cut this off a bit, I'll pass this around for people to look at. So you'll have to imagine that that portion of that catheter is actually cut off and it's just friction fit in there. Realize that that number, that CO2 number, may actually be falsely low because it's being washed with oxygen all the time. But again, we don't really know what their lungs are going to be like, so the number we get for Entitled CO2 will really be based on, or at least a starting point for what we're looking at, for how well they're actually ventilating, and how much volume they're moving. Does that make sense? Is this the things that you want? I think your slides that you're showing with different waveforms are fantastic to see. Are good examples of troubleshooting and finding out what's wrong with those particular devices. I'm just going to try to calibrate this up. And then we can get somebody breathing through an ET tube if you want. Do you want to do that?
Myron,
Yes, sir.
how long does it take to set up the side stream CO2 monitor?
Seconds.
Seconds? So it's just the main stream that takes 3 to 4 minutes?
Click it in. Yeah, this will take 3 to 4 minutes. What we've done with the RT side is we try to have them go down every day and set it at the big site for sure. I'm not sure what we're doing today. Please step it if I'm wrong. Now we have a side stream, we don't need to do that anymore. Just plug it in, click, it's there in seconds. It's fantastic.
Can I make one comment that Adam shared with me? If they come in from with the paramedic, their monitors are capable, although they don't always use it, and he has them stay on, asks them to keep their monitors on until we're connected here, just as a practical point.
As you can see here, there's a lot of potential uses. So verification of tube placement, continuous monitoring of the tube location during transport, effectiveness of CPR, prognosis in cardiac arrest, prognosis in trauma, can be used as an indicator of return of spontaneous circulation during chest compressions, can be used to maintain eukapnia in a patient with increased cerebral pressures, and can be used for adequacy of ventilation. So first, the verification of ET tube placement. Following intubation, the presence of a waveform with all 4 phases indicates that the ET tube is through the vocal cords with 100% sensitivity and 100% specificity in some studies. But do note that you can get a normal-looking waveform initially with a right main stem bronchus intubation. A flatline waveform in a patient who has recently arrested or who's not arrested usually indicates esophageal intubation. But again, a flat line can occur, as we said earlier, with prolonged cardiac arrest with diffuse cellular death, can occur in tracheal placement with inadequate pulmonary blood flow, in complete ET tube obstruction, complete airway obstruction, or of course, technical malfunctions. So how are we currently checking for ET tube placement? We've got the colorimeter. We look for gas or vapor in the tube. We watch it go through the cords. We listen for bilateral breath sounds. Sounds pretty good. But I found a study that showed that condensation in the tube can occur in up to 83% of esophageal intubations. That chest wall movements can occur with both tracheal or esophageal intubations. A neat study in the late 80s took anesthetists in a controlled environment. They were blinded to whether or not the patient was intubated in the esophagus or in the trachea, and they were asked to verify where it was just based on auscultation. And they incorrectly identified it in 16% of cases. This is a quiet, controlled environment, one-on-one anesthetist and patient. So what about this versus qualitative Entitled CO2 measurement? We've got the colorimeter, it turns yellow, works perfectly. In patients with low perfusion states, the qualitative capnography can be up to 100% sensitive. But the colorimeter has more variable sensitivity because the exhaled breath or the exhaled concentration of carbon dioxide can fall below the detection threshold, especially in someone with cardiac arrest, poor perfusion, weak chest compressions. The Entitled CO2 could be below 10, and you may not get a great, complete yellow turn in the color. All right, so although the accuracy of capnography in verifying ET tube placement in patients with spontaneous circulation or in early arrest can reach up to 100%, in late cardiac arrest, it can be quite variable. Some studies have reported down to 62%. That's also depending on the modality used. But again, knowing this, if you see a waveform in an intubated patient, you can assume that it is in the trachea. You're not going to get a waveform when it's in the esophagus. And early in arrest, or in someone who has a pulse, a flatline waveform will most likely indicate esophageal intubation. So remember that early in cardiac arrest, when the patient's receiving effective CPR, complete failure of carbon dioxide exchange is unlikely. So again, if you're seeing 0, it's not likely that you have a successful intubation or an unsuccessful intubation.
Sorry, when you consider prolonged arrest, just out of curiosity, how long do they have to be arrested for to lose the waveform?
That's a good question. I don't know. I don't have an answer for that. When I was reading in the studies, it said just long enough to have diffuse cellular death. And after 20 to 25 minutes of an arrested patient with CPR, the Entitled CO2 has been shown to start dropping off, and that's a measure of prognosis. But I don't know how long it takes to get to 0. But the bottom line is that physical assessment and assessment of capnographic waveform should be considered co-primary.
I would just say those people who are at 0 are people you're going to walk in the room and say they're dead. I mean, those are, in my experience using this in arrested patients, would suggest that these aren't people that were arrested 5 minutes ago. These are people who have other signs of death already, like externally visible. You know, they've been standstill, clotted blood in the pulmonary arteries kind of situation. Because otherwise, I've run prolonged arrests on people with Entitle that, you know, and it never quite goes to, like, you're talking 0. Like, yeah, you're not going to have any trouble recognizing who those patients are.
So this is also recommended through the American Society of Anesthesiologists, who in an updated 2011 guidance stated that capnography should be used in all patients receiving moderate or deep sedation, which of course includes all patients who are intubated. What about monitoring during transport? A prospective observational study of 153 pre-hospital intubations found quite an alarming rate, 23% of unrecognized misplaced intubations among patients without continuous end-tidal CO2 monitoring. And those patients who had continuous monitoring achieved a rate of 0%. In another controlled study of intubated blunt trauma victims, patients assigned to capnography-guided ventilation during transport were significantly more likely to arrive at the emergency department appropriately ventilated and eukapnic based on PA CO2 levels drawn by arterial blood gas upon arrival. Orange is currently using this at the advanced care flight paramedic and critical care flight paramedic level. All land DMS is equipped to use the colorimetric Entitle CO2, but some advanced care paramedics in London and Windsor have the PhysioControl Life Pack 15s, which have Entitle CO2 sensors for intubated patients. Let's talk about the effectiveness of CPR. During cardiac arrest, alveolar ventilation and metabolism are essentially constant. We're controlling for them. So therefore, Entitle CO2 should reflect pulmonary blood flow and can therefore be used as a gauge of effectiveness of cardiac compressions. As effective CPR leads to higher cardiac output, Entitle CO2 will rise, reflecting the increase in perfusion. A study using Entitle CO2 measurement in out-of-hospital cardiac arrest concluded that capnography can detect the presence of pulmonary flow with compressions even in the absence of palpable pulses. 2010 AHA guidelines on cardiopulmonary resuscitation and emergency cardiovascular care stated that real-time monitoring and optimization of CPR quality using when feasible physiologic parameters like PET CO2 are encouraged. And when quantitative waveform capnography is used for adults, the guidelines now include recommendations for monitoring CPR quality, as we just discussed, and detecting return of spontaneous circulation. So how will this appear? When you're giving optimal chest compressions for effective CPR, Entitle CO2 values should be between 10 and 20 millimeters of mercury. If those values are dropping below 10 or decreasing after the initiation of ACLS, this is either associated with poor prognosis and a prolonged code or operator fatigue. So looking at this capnogram taken during resuscitation, notice the trough in the center. The initial capnogram sitting just over 10 millimeters of mercury, and then the trough where there was a change in personnel during CPR. The fatigue of the first rescuer is demonstrated when the second rescuer takes over compressions and you get up to 20 millimeters of mercury return. Now, there was a study that tried to talk about limitations by giving bolus doses of epinephrine, dropping the end-tidal CO2, which may skew your results, but the drop on average was 0.3 millimeters of mercury, and when we're talking about keeping it between 10 and 20, who cares? Now, they can go on to say, well, maybe we can use this in terms of timing of end-tidal CO2 bolusing, but I would argue that during a code, you're not going to be able to notice a 0.3 difference in the capnogram. We're talking about big swings, so let's ignore those limitations. Prognosis in cardiac arrest, as I've already briefly noted or spoke about, there are several prospective observational studies showing that levels less than 10, when effective CPR is being given, 20 minutes after the initiation of ACLS, accurately can predict death in adult patients with cardiac arrest. So it's an adjunct in terms of your decision of whether or not to continue with resuscitation. Return to spontaneous circulation. Multiple studies have shown that end-tidal CO2 is the earliest indicator of return to spontaneous circulation. At this point, the patient is non-responsive, you're giving chest compressions, and you have to wait till the next interval when you stop compressions, check for a pulse. And now we see, oh, they have a pulse, they're in normal sinus. But the end-tidal CO2 will jump during compressions when you have return to spontaneous circulation. This is because when the heart restarts, the dramatic increase in cardiac output and resulting increase in perfusion leads to a rapid increase in end-tidal CO2 as the carbon dioxide that's accumulated during the arrest is effectively transported to the lungs and exhaled. So as I said, this will manifest as a dramatic rise in the waveform. So this virtually eliminates the need to stop chest compressions and check for pulses when you believe there's been a return. This is also mentioned in the 2010 AHA guidelines, and this is how it's manifested. As you can see here, the initial waveform is indicating chest compressions. We've got end-tidal CO2s between 10 and 20. The trough, when it drops to 0, was for defibrillation. So the patient was successfully defibrillated. They have a return to spontaneous circulation. And although you'd be starting chest compressions anyways, you can look to the monitor and see now the end-tidal CO2 is up to 50. One thing that we're not using it for yet, but may potentially be used in the future in the emergency department, is the head-injured patient who is intubated. As we know, arterial carbon dioxide tension affects blood flow to the brain. So high CO2 levels result in vasodilation, which can, high CO2 levels result in cerebral vasodilation, and low result in cerebral vasoconstriction. And sustained hypoventilation, when your PaCO2 rises above 50, can result in cerebral blood flow and increased ICP, which of course is harmful. And sustained hyperventilation, when your PaCO2 is less than 30, is also detrimental. The Brain Trauma Foundation recommends eucapnia in the intubated patient with increased ICP. A prospective observational study found a lower incidence of inadvertent hyperventilation among intubated patients with severe head injury who underwent continuous capnography monitoring compared with those without, 5.6 versus 13.4%. It can also be used as a prognosticator, although the numbers are not.
I think the unspoken thing here is that you're talking about Entitle and you're talking about PaCO2 in the same.
Sorry, so yes, this is PaCO2 in terms of measurement. What I'm talking about is that without having to draw arterial blood gases, you can maintain eucapnia using the End-tidal CO2 in the emergency.
Oh, wait, like, so you're suggesting there's 100% correlation between
No,
the
no, I'm not suggesting 100%.
So I think that needs to, are you going to discuss that, or do you want me to comment on that, or?
If we could, I'd love to.
So there's something called there's like a gap between the Entitle and the PaCO2. Typically, whatever your Entitle is in a normal healthy patient, your PaCO2 will not be lower than that, and often will be a few millimeters of mercury higher than whatever your Entitle is. So for example, if you're in a traumatic brain injury patient, if your patient has an Entitle of 40, their PaCO2 is certainly at least 40 and probably a few millimeters of mercury higher than that. And that gap, though, can vary patient by patient based on all the factors that we're discussing: pulmonary blood flow, anatomic and physiologic dead space fractions, those kinds of things. But assuming all other things being equal, you can't use it as a 100% guide, but it's often 4 or 5 millimeters of mercury higher in the blood than what you see on the screen. I think that's important to know that they're not 100% correlated, and every once in a while, depending on the patient's physiology, you might get really surprised by a more significant gradient. And I'll send out an article after that talks about that a little bit to the group, just to read up on.
Sorry, so are you going to aim for 35 then in a head injured patient then, or something?
I think that's perfectly fair. Yeah, I think 35 would be great, because then you're at least 35 and probably more like 40, and that would meet the eucapnia description. So I think that's a good.
But once you establish that correlation, it's not likely to change within that individual patient. Is that
right? So if you did draw an ABG and then you sort of calibrate them, less sort of practical in the ED, where we often don't hang on to these patients, at least in 2013, for these kind of prolonged resuscitations. But often we have an arterial gas at the same time, and you can and I would encourage people starting out to use this in these settings to do an arterial gas to kind of get their own almost level of calibration with how the technology works.
Great, thank you. The bottom line, and this is directly from the guidelines, is that quantitative measurement of end-tidal CO2 may be a safe and effective non-invasive indicator of cardiac output in CPR, and an abrupt increase in end-tidal CO2 may be an early indicator of return of spontaneous circulation. At this point, there's insufficient evidence to support or refute a specific threshold at different time intervals as a prognostic indicator, but just as an adjunct in your clinical decision for terminating resuscitation. I'd like to now briefly touch on two potential uses in the non-intubated patient, which we do have capability for. Some of the uses are procedural sedation, monitoring ventilation in the obtunded patient or unconscious patient who's not going to be intubated, acute respiratory distress, and detecting metabolic acidosis. So as we know, it's difficult to predict how someone will respond to administering a sedative. And incidence of hypoxia is less if capnography is used, because as we talked about earlier, hypoventilation and apnea will precede hypoxia. When capnography is used in conjunction with pulse oximetry and visual inspection of the patient, of course, I found a study that showed respiratory depression was detected 17 times more often. One other study showed that capnography can forewarn impending hypoxia for anywhere between 5 and 240 seconds, and therefore triggers earlier intervention. Again, going back, the American Society of Anesthesiologists and the Association of Anesthetists of Great Britain and Ireland both recommend in 2011 that anyone with moderate to deep sedation get capnography. So here's...
Are you aware of any studies that show a change in patient outcome associated with apnea? Or not apnea, but hypoxia during procedural sedation?
No. And that's a great point, and one that...
It's a surrogate, right?
I would say hypoxia, yes, but maybe not hypercapnia. Is that what you mean?
Wow. Either.
Either
Well,
way.
is
They're both
Yeah.
so short.
Yeah, it depends on how short-lived it is, obviously.
I'm going to leave that up for discussion at the end. So just to go through some of the equipment that you can use in procedural sedation. So this is a mask actually built to have the attachment of the tubing, but of course, as we've shown earlier, you can actually put an 14-gauge angiocath into one of our simple masks and do the same. There are nasal cannula with tubing attachments. And this is a separate type of nasal cannula with a side stream port tube that comes directly off of the line. So how would we use this? And I have a little flow chart here to break down using Entitled CO2 in procedural sedation. So if it is increasing, of course, the patient is hypoventilating. If it's 0, the patient could possibly be apneic, could have complete obstruction, or could be a sampling issue. So of course, turn to the patient and try to determine which it is. And if it's decreased, it could be partial obstruction, could be hyperventilation, or it could be hypoventilation and you're not getting adequate sampling. So look at the patient. If it's increased respirate, they're hyperventilating. Could be due to increased pain during your procedure. If it's decreased, it could be partial obstruction, so it could be all they need is a jaw thrust. And if that resolves, then it was partial obstruction. And if it's not relieved, then it could be due to hypoventilation. Lastly, I talked about detecting metabolic acidosis in the non-intubated patient. So there's a linear correlation between serum bicarb and Entitled CO2. And this is found in two studies, actually 3, but 2 that I looked at, pediatric patients with DKA or gastroenteritis. So as the patient becomes acidotic, bicarb decreases, causing an increase in minute ventilation, which results in a compensatory respiratory alkalosis. And this process results in decreasing Entitled CO2. And you can see that's in a linear relationship. Just making sense of this chart. So the 0s are all people that had bicarbs greater than 19, and the 3s are people that had bicarbs less than 10. You can see with the Entitled CO2, all the 3s fall 20 and below. And although 1-0 is in the high 20s, the vast majority are above 35. A final thought on the limitations of Entitled CO2 monitoring. It's most effective when you're assessing a pure ventilation issue, a pure perfusion issue, or pure metabolism problem. So great in cardiac arrest when we're controlling for 2, we're essentially assessing perfusion. But if you have mixed problems, mixed ventilation, perfusion, metabolism problems, it makes it a lot more difficult to interpret. So for example, a ventilation problem may elevate your Entitled CO2, or a perfusion problem will simultaneously decrease it. You get a patient with pulmonary edema from an acute underlying myocardial infarction who now has decreased cardiac output. I'd now like to ask the crowd if anybody's been using this and what they found worked well, what they liked, what they didn't like, if they had any issues, how they troubleshot those issues.
One of the areas that I think it's most useful for in emergency medicine, other than endotracheal tube placement, is following cardiac output post-arrest, which you alluded to in your introduction, talking about physiology. But after the patient's been resuscitated, they've got spontaneous circulation, you're monitoring their Entitled CO2, we're fumbling around trying to get outlines in and things like that. It can be a nice early indicator of when their cardiac output is starting to drop. If, assuming that they're adequately ventilated, their Entitle starts dropping, and you can start getting the pressor support ready or start getting ready to do CPR again. It's just a really good indicator that your cardiac output is dropping.
they don't have experience with it.
And when you work in GCCU, you use it a ton. They always use it, and it's great for assessing not only the weird cardiac patients you get in pediatrics, but also sepsis has been very useful in seeing when you're having different changes in how your treatment's going, as well as some of the traumatic head injuries. So in the pediatric ICU, I think we have it constantly going on all the patients. I found it was a very useful, non-invasive marker of what was going on with the patient, and during those 2 months came to look for the number quite frequently, so I relied on it heavily and found it very useful.
Any ED experience with it?
Just when those guidelines first came out, we tried it about 3 times downstairs for the cardiac arrest. But you know, as Myron alluded to, by the time he got warmed up for 2 minutes and then did the calibration didn't seem to work that well, and so I think it worked about 1 out of the 3 times that we tried.
So that was the inline, but now we've moved on to the.
So knowing now that it's a lot easier, it's pre-calibrated, you just plug it in, do you think you'd go back to using it?
Yeah.
So I use this pretty extensively when I was in the States, and the ED was like a part of the culture, including procedural sedation, which I think is a separate topic, and I sort of get Crispin's, I think I'm reading between the lines that I think you and I agree that it's maybe an extra piece of data that you're actually not necessarily going to act on, and some people feel very strongly the opposite, and those who use no oxygen, so they have earlier alert to apnea as well. But in the cardiac arrest or the critically ill patient, I mean, it's an extremely sensitive, extremely time-responsive indicator that physiology has changed. And I agree completely with Bill that any fluctuations in Entitle, most likely, barring again excellent troubleshooting points you made about like airway obstruction or equipment failure, signal the patient's physiology has changed. And otherwise, we don't always have, you know, the other tools we use currently are not that sensitive and that time responsive. So I think in the patient in cardiac arrest, it's extremely helpful. You know, we use it as an adjunct with echocardiography and Entitle. If you have, you know, stand still hard and Entitle of, you know, less than 10 during CPR, I mean, you're done, right? You have now 2 strong data points to support termination or resuscitation, which I think helps everybody. And in turn, also during CPR, when you see that huge shoot up of the Entitle, again, the physiology has changed, and you're justified in actually ceasing compressions at that point and doing a pulse check, just if there's a big enough rise in the Entitle, so you don't need to kind of carry it on any further. So I think it's a fabulous tool. I think it's great for cardiac arrest particularly. The other applications are, you know, I don't endorse or didn't find as much use for, including procedural sedation. But I'm very interested to see kind of how everyone gets along with this, and anyone else have any thoughts? Or Crispin, was I reading between the lines correctly? You plan on not using this for procedural sedation, or you plan on?
I have yet to see anything that's told me that I should be chasing this number in procedural sedation. I'm not the guy who does it without oxygen because I want early warning. No, I don't actually care about apnea all that much. Yeah. As long as it's short and all that sort of jazz, as long as they don't deoxygenate, I don't really care about hypercapnia in these otherwise healthy people. So I'm less concerned about this unless I see something that says, you know, there is a strong correlation between patient outcome and hypoxia, and that can be best seen, or the best early warning sign is hypercapnia, and this is how we can make things safer and better. I just haven't seen it yet, and so that's what I was wondering if there was something that was out there that I missed.
suspect it's more important in the people who have multiple medical problems. You know, who's kidding who, if they're 18 and they're healthy, if they're apneic for a while, nothing's going to happen. But the person who's probably not going to do very well with that is going to be the, you know, 75-year-old who has multiple medical problems and whatever. You know, they're going to be the person who's going to go on to have an arrest now that they had a brief apneic period. So, you know, you don't want to be doing chest compressions during your sedation.
You focused a lot on using this in ACLS and CPR. Would you say that every patient who's sick enough to be intubated should also have continuous capnography?
I think if they're going to be sitting in our department intubated for any prolonged period of time, based on what I've been reading, then yes, I think they should all have continuous waveform capnography. As Dr. Arnfield said, these sick patients, it's such a rapid indicator of any change in their physiology. So absolutely.
This may seem like a dumb question. Now that we're moving towards the side stream and it is so easy, why aren't we using it all the time with our intubated patients?
one of the peds intensivists locuming here from Ottawa asked me what I was preparing for, and I told him, and he said, well, why? Like, aren't you using it already? And he was just shocked to hear that we weren't, because it was just standard of care in Ottawa. Whatever that's worth.
Yeah, I think a pediatric ICU is very different than an adult.
No, he said in there.
Yeah,
Sorry, wait, are we suggesting putting this on every single patient?
possibly a triage.
Another vital sign.
Well, actually, because pulmonary embolism is a disease of dead space, it obstructs pulmonary blood flow. Jeff Klein and the North Carolina group look at point of care Entitle as a kind of again trying to find a point of care risk stratification tool to determine people at risk for pulmonary embolism. Because one of the things that happens when you get a big PE, if you have if in the OR or something, you have a capnogram and it just drops off because your pulmonary blood flow drops off because you have a big clot sitting there. So the idea of using it as a vital sign or a triage for somebody with respiratory distress, who knows what information that could lead to. But
Boo from the nurses.
We were actually talking about using this as part of the CCOT assessment piece for any decreased LC. So you can throw that on with the decreased LC as long as you have a side stream. And if the CO2 comes back at 80, you already know that they're...
it's at least 80.
And that way we don't have to wait the 10,
The gas.
15, 50 minutes for the gas to come
That's a
back.
great idea.
And that will just save a little bit of time.
That's a great idea.
Thank you, everybody, for coming.